Good afternoon. I'd like to welcome you all to the ADNeT Memory Clinic webinar series. We are delighted to have two excellent speakers today, and they will be focusing on frontotemporal dementia and dementia with Lewy bodies in relation to current understanding, management, and clinical trials. And as you can see from the slide, that a recording of today's webinar and previous webinars will be available on our YouTube channel. So in a moment, I'll introduce the speakers. My name is Pravinder Sachdev, and I'm Professor of Neuropsychiatry at the University of New South Wales, and I'm the lead investigator along with Professor Sharon Naismith from the University of Sydney on the Memory Clinics Initiative of ADNeT. And I'd like to introduce ADNeT, but before that, I'd like to acknowledge the traditional custodians of country throughout Australia and their continuing connection to land, sea, and community. We pay our respects to all Aboriginal and Torres Strait Islander people, their cultures, and to their elders, past, present, and emerging. So, ADNeT, or Australian Dementia Network, was a large national network which was funded through the NHMRC and an IDR boosting dementia research grant about two and a half years ago. We're about midway in our funding, and it was an $18 million grant. And the idea was to bring the dementia researchers across the country together. Three large initiatives. The first initiative was to develop a clinical quality registry for dementia, and that work is being led by Monash University researchers, and it's well on its way towards the initial pilot stages. And the second initiative is to harmonize and bring together memory clinics from around the country to look at improving the diagnostic assessment and also post-diagnostic care through these memory clinics. And that's the initiative which is responsible for organizing this lecture series. And the third initiative relates to developing a trial-ready cohort. The idea is to increase the speed of development of effective therapies, to bring trials to Australia, to make them available to people with dementia and mild cognitive impairment throughout the country, and to also bring the newer technologies in terms of amyloid imaging, CSF biomarkers, etc., for the assessment of dementia, in particular Alzheimer's disease. And the two other initiatives that are part of ADNeT, which are support enablers, are ADNeT Technology and ADNeT Business. And ADNeT is collaborating with a number of companies and other businesses so as to increase the funding for dementia research and to make it a viable proposition in the coming years. With that, without further ado, let me introduce the two speakers. The two speakers are firstly Associate Professor Rebekah Ahmed. Rebekah is an NHMRC Early Career Fellow at the Brain Mind Research Centre and staff specialist at the Royal Prince Alfred Hospital, where she's the director of the Multidisciplinary Memory and Cognition Clinic. She's a senior neurologist at the Frontier Group at the Brain Mind Centre. She graduated in medicine at the University of Adelaide, won the University Medal, and completed neurology training at the Prince Alfred Hospital. Then she got the Australian New Zealand Association of Neurology Fellowship to the National Hospital Queen Square, where she completed a clinical fellowship and also did a fellowship at the Dementia Research Centre, University College London. Her PhD focused on eating and metabolic abnormalities in FTD and ALS. She's a clinical scientist with research focusing on metabolic markers in neurodegeneration, particularly FTD. And Associate Professor Rosie Watson is a geriatrician at the Royal Melbourne Hospital and a joint laboratory head at the Walter Eliza Institute of Medical Research. Her research interests include improving the diagnosis and care for people with cognitive impairment and dementia. She leads a longitudinal clinical biomarker study of DLB and is establishing a new clinical trial for its treatment. She's also a member of Dementia Australia Scientific Panel and supervises trainees in geriatric medicine as well as PhD students. So over to you, Rebekah.
So thank you again for the opportunity to present. So really what I wanted to do today is give you an overview of what has actually been a really exciting year for research and clinical trials in frontotemporal dementia. The rest of the year has been pretty horrible, but actually there's hope in FTD this year that we haven't had for many years. So for about the last 20 years in frontotemporal dementia research, we've been really good at documenting the changes. So we know that FTD is the second most common form of young onset dementia. It typically affects those less than 65 years. And patients particularly have changes in emotion processing, also memory changes, also changes in eating and metabolism, and also psychiatric symptoms. And what we've shown is that we know the structures of the brain that cause these changes, and we can diagnose patients with the different forms of FTD clinically. But there are still a number of key questions that the research community in FTD has really struggled with. So when we see patients with FTD, we don't know how we differentiate between what we would call fast progressors and slow progressors. So for example, sometimes we'll see patients that will decline over a 4-year period, but then we have other patients that will survive 15 to 20 years. We don't know what factors modify survival, and we have difficulty in predicting the underlying pathology and the genetics clinically. We don't know how to prognosticate for patients and families, and that often affects what patients we will eventually include in clinical trials. And once we have potential drug treatments that we can treat FTD with, we have difficulty in knowing what markers we will use to determine if those drugs are effective. So whether we use clinical markers, biomarkers, or survival time. We've recently been doing a lot of research at looking at what factors will improve survival and what factors will lead to poorer survival. And what we know is the patients that typically have a poorer survival with FTD are those patients that are apathetic, have an unfavorable lipid profile, have concomitant language impairment, and have a number of genetic mutations. But also on the other side of that, we know what factors may improve survivals, including changes in eating habits and low CSF or serum neurofilament light chain. And then there are a number of factors in between that may or may not affect survival. Recently, we looked at our cohort of FTD patients that we have at the Brain and Mind Centre, and we looked at 75 cases of patients with behavioural variant FTD. And what we found was that the median survival for those patients was about 10.8 years. And patients had a shorter survival if they had a shorter disease duration, poorer visuospatial function, if they had more behavioural symptoms, and were older in age, and greater atrophy of the anterior cingulate cortex. We also looked at other factors that may affect survival, and what we found was that those patients who initially presented with a cognitive or behavioural profile had a better survival than those patients who initially presented with motor symptoms. And this was related to different patterns of atrophy in the brain. So there are a number of factors that we can use to predict survival. And that's important when we look at treatment options in FTD. So the FTD community has been very slow behind the Alzheimer's disease community in terms of what drugs we have trialled. So this is a figure of all the drugs that have been trialled in Alzheimer's disease. And up until this year, essentially in FTD, all we had to offer patients was symptom management with atypical antipsychotics and selective serotonin reuptake inhibitors, and managing carer burden. But this year there's been the establishment of what we call the FTD Prevention Initiative, and that's really brought together centres around the world that specialise in FTD research. And what they've done is collaborated together to try and work with pharmacy and big drug companies to come up with different treatment options for FTD. And really, the first part of this initiative has focused on the genetic forms of frontotemporal dementia. So we know that there are several genes that cause FTD, the main ones being C9orf, granulin, and MAPT mutations, and then some lesser common genetic mutations. And the drug treatments at the moment have really focused on those groups to see if there is any effect. And there are a number of clinical trials that have started in FTD that focus on both asymptomatic patients, symptomatic patients. Some of them are preventative, some of them are disease modifying, and some of them are symptomatic therapies. And so what I wanted to take you through now is the 4 clinical trials that have started this year in 2020. So the first study is called the PROCLAIM study, and essentially this study has really focused on patients with FTD with granulin mutations. So we think probably about 10% of patients who have FTD have a granulin mutation. And granulin is an interesting protein in the body, and essentially it has a number of factors, but it's secreted in lysosomes, and it has a role in inflammation. And what we think happens is patients who have an FTD granulin mutation actually have reduced levels of progranulin in their system, and that leads to lysosomal dysfunction. We know that progranulin has a role in inflammation, metabolism, wound healing, tumorigenesis, and also microglia function. And what we know is that patients who have a mutation, so when we compare progranulin levels in serum and CSF, we know that patients who are asymptomatic and have a mutation and symptomatic who have a mutation have reduced progranulin levels in their serum and CSF compared to patients that are non-carriers. We know that granulin mutation carriers can present with a wide spectrum of symptoms, including FTD, Parkinson's symptoms, cortical basal syndrome, and also Alzheimer's disease phenotype. So they look like they have Alzheimer's disease, but actually they've got an underlying granulin mutation. And we know that the underlying pathology of this is TDP43. So what we know is that if you have no mutations in the granulin gene, you're normal. If you have one mutation, so you're heterozygous, you have frontotemporal dementia, and that's usually adult onset. And if you have 2 mutations, then that's homozygous, and that's childhood onset of a condition called neuronal ceroid lipofuscinosis. So really this first trial is very exciting in the sense that it's targeting gene therapy. So gene therapy is really advanced, and essentially it's a hope for patients with genetically defined diseases. And what gene therapy does is it inserts a healthy copy of a gene or genetic material into a patient's cells to compensate for the abnormal or mutated gene. And then that potentially allows the body to produce the protein that the normal gene would make and overcome the faulty gene. And many of these gene therapy approaches use a viral vector. So they attach the genetic material to a viral vector. And so what this trial will involve doing is that they attach a copy of a normal granulin gene to a viral vector, and then they insert it into the body, and then essentially their hope is with that genetic material it will travel into the nucleus of the cell and replace the faulty gene with a normal gene, and that normal gene will then produce progranulin, which will help to overcome the effects of FTD. So this company, Prevail, which is running the first trial, has done a lot of studies and research using this viral vector called the adenovirus, or AAV9. And it's being used extensively in other neurological diseases, including Parkinson's disease. And essentially what their aim is to do is to directly treat the underlying cause of FTD. And so what they'll do is they will attach the granulin gene to the viral vector, And then patients need to undergo what we call a cisternal puncture, which is essentially like a lumbar puncture, but we do it higher up, just at the base of the skull, and we inject the gene into the CSF, and the hope is that that gene will then travel into the brain and replace the abnormal genetic material. So they've done a lot of research in preclinical models and have shown, and animal models, and it's been shown to increase progranulin levels in mice models, and also to reduce neuroinflammation and lysosomal deficiencies. It hasn't been trialed in humans as of yet, so this first study is a trial in humans. But as I mentioned, this type of method has been used extensively in other neurological diseases, including, for example, Parkinson's disease and Huntington's disease, and is found to be safe. And these are some results from the mouse model where they use this treatment, and what they've found is there's increased progranulin expression of messenger RNA, there's reduced lysosomal dysfunction, and there's also reduced neuroinflammation. So this is a promising trial, but quite complex. So the key aim of this study is to look at the safety and tolerability of this new treatment, and then look at key biomarkers, including progranulin levels, neurofilament light chain, and MRI changes. Essentially, in this trial, what we're looking for is patients that have a diagnosis of frontotemporal dementia and who are known to have a granulin mutation, or there is a suggestion that there's a granulin mutation in the family. The patients need to be living at home. So we can't do it in patients who are already in nursing homes. So they have to be still living at home and able to participate in the trial. And essentially the endpoints are to look at the safety and tolerability of this, and whether this treatment will increase progranulin levels. So I think this is an exciting new trial, but it's quite complex, but it's a new, I guess, frontier in FTD research. The second trial that I wanted to talk to you about is also focusing on patients with frontotemporal dementia. And again, this is run by a company called Elector. And again, they are also looking for patients that we know have the granulin mutation that cause FTD. And essentially, this is a bit more advanced than the first study, in that it's a phase 3 study. And essentially, they want to look at patients who, again, have the progranulin mutation. But the interesting thing about this study is it's in patients that both have symptomatic FTD and have the genetic mutation, and also those patients that are pre-symptomatic and have the progranulin gene mutation. So essentially, this trial uses a different approach to the first trial. So Elector has produced this compound called AL001. And essentially, the aim of this is it's a monoclonal antibody, and it aims to increase your progranulin concentration. So remember, at the start of the talk, I mentioned patients with granulin mutations causing FTD have a reduction in progranulin. So the aim of this study is to use this monoclonal antibody to block a receptor called the sortilin receptor, and essentially stop progranulin from being taken up by cells and broken down. So its aim is to increase progranulin levels in patients. This again is in patients who are known to have a granulin mutation and either have FTD or are pre-symptomatic for FTD. And essentially, the interesting approach that this trial is using is that they want to use neurofilament light chain as a way of selecting patients that will be able to participate in the studies. So neurofilament light chain is an interesting protein that we think comes from axonal degeneration. And studies have shown that neurofilament light chain is increased in patients who have neurodegenerative diseases. So this study looked at cerebrospinal fluid neurofilament light chain levels. And what they found was that it was increased in Alzheimer's disease, but particularly increased in patients with frontotemporal dementia and motor neurone disease, and also in dementia with Lewy bodies. And so there's much hope in the neurodegenerative community that neurofilament light chain will be a marker of how close patients are to getting the disease and their disease progression. And this study wants to only select patients who have an elevated neurofilament light chain level. We also know this study looked at neurofilament light chain in genetic forms of FTD, and I'll just draw your attention to this graph, which showed that particularly in patients with the granulin mutation, their neurofilament light chain levels were particularly elevated compared to controls, and also patients with other genetic mutations that we know cause FTD. The reason why that's the case is we're not sure about, but it could possibly indicate a more kind of severe disease course. So again, this study is for patients with FTD and a granulin mutation. It's essentially looking at both clinical and biomarker outcomes, and also safety and tolerability of this monoclonal antibody. The good thing about this trial is it's also in symptomatic and pre-symptomatic patients, but it is a quite intensive program. So if you're pre-symptomatic, it's a 96-week treatment program of monthly infusions, whereas in patients who are symptomatic, it's a 48-week treatment of the monoclonal antibody, so every month for 2 years, or a bit under 2 years. So that's the two trials that are dealing with the granulin mutation that causes FTD. What I wanted to look at now is that a study that's actually based in Australia and it's come out of Melbourne. And essentially with the granulin mutation, we've focused on cases of FTD that we know are caused by TDP43. The study that's come out of Melbourne is really focusing on cases of FTD that we think have underlying tau pathology. And essentially, this is using a drug called sodium selenate, and this is an oral drug. And essentially what the take-home message is, sodium selenate works to reduce the amount of phosphorylated tau that you have in your brain. So we know that phosphorylated tau is potentially dangerous and bad for neurodegeneration. So what this drug does is it aims to dephosphorylate tau. It's been trialled in a number of mouse models, and it's been found to reduce the levels of total tau and phosphorylated tau and to reverse memory deficits. And it's also been trialled in human studies in traumatic brain injury and epilepsy and found to have some promising effects. They've already done a phase 1b trial in patients with behavioural variant FTD. And essentially they looked at 12 patients over a 12-month period, and they found that the oral drug was safe and well tolerated. And interestingly, there was no change in cognitive or behavioural symptoms. And it was felt on imaging analysis that there was a slowing in brain degeneration. And this study is due to be completed in December of 2020. And this graph just shows they used as a measure of cognition the new cog score, and across the patient group, there wasn't a decline over a 12-month period. So there are some promising results for the sodium selenate trial. The trial that they're looking to recruit for is a phase 2 trial that will be run across both Melbourne and Sydney, and I think they've added a site in Brisbane as well. And it will involve 12 months of treatment with an oral drug, selenate, and look at cognitive outcomes, behavioural outcomes, levels of tau, protein on both serum and CSF. And that's, we're due to start recruiting for that trial late this year, early next year. Again, they're looking for patients that have a diagnosis of behavioural variant FTD. The good thing about this trial is you don't need to have a genetic mutation. So the first 2 trials, you needed to have a granulin mutation or be suspected to have a granulin mutation. In this trial, you just have to have a diagnosis of behavioural variant FTD. And as well be living in the community with someone who's willing to come along with you for the duration of the study. again, they've got standard exclusion criteria that we normally see for drug trials. So the last study that I wanted to talk to you about is a study that we're running out of Sydney. And the first 3 trials, we're really looking at underlying pathology and changing disease progression. This trial using oxytocin is looking at symptomatic management. So we know that this drug oxytocin, which is sometimes called the love drug, has a real effect on emotion processing. So we know that oxytocin can improve social behaviour, emotion recognition, interpersonal trust, and these are many of the things that we see are abnormal in patients with FTD. Oxytocin, which is given as a nasal spray, has been demonstrated to have positive effects in patients with autism, social anxiety, and schizophrenia. And essentially, it's a safe and tolerable in patients with FTD. And there is some suggestion that it can improve neuropsychiatric symptoms, emotional behaviour, and overall behaviour, and reduce carer burden. So this study is a much shorter study. It goes for a month, and it involves essentially patients coming in, and they'll be divided into either the first group will get oxytocin and the second group will be placebo, and then they'll have phone follow-up, and then at the 2-week mark they'll cross over. So if the patient didn't get oxytocin in the first part of the study, they will get it in the second part of the study. And this is really aimed to look at, does oxytocin improve behaviour and improve emotion processing? So there'll be a number of tests looking at social and emotion processing and behavioural symptoms, and also blood will be taken to look at oxytocin levels. So these are the contacts if you would like or have patients that would like to participate in any of these studies, or if you've got any questions about the studies. So in Sydney, we're running the Proclaim study, the Elector study, the Selenate study, and the oxytocin study. Melbourne, Amy Brodman is running the Elector study, and Professor Terry O'Brien is running the Selenate trial. And there's a contact of Lucy. If you're in Sydney, please contact our trials coordinator, Cassandra. And if you're in Perth, Dr. Carolyn Orr is running the Elector study and is happy to be contacted as well if you have any patients that you think might be suitable for these trials. So really, the message from my presentation is 2020, while it's been a horrible year for all of us with what's been going on, it really is a year of hope for FTD, because for the first time we've got 4 clinical trials. And if you'd asked me 12 months ago, would there be any clinical trials in FTD, I probably would have said no. But this year, luckily, we've got 4. So I might leave it there, and I'm happy to take questions at the end. Thank you very much.
Today I'm talking about Lewy body dementia and really focusing on the diagnosis, the management and clinical trials. Dementia with Lewy bodies, it's a really common form of neurodegenerative dementia in older people, second only to Alzheimer's disease. The characteristic symptoms include problems with attention, visuospatial function, executive function, and also relative preservation of episodic memory, which is quite different, I guess, to Alzheimer's disease. Other features include visual hallucinations, cognitive fluctuation, motor Parkinsonism, and it can be very difficult to diagnose, and dementia with Lewy bodies is frequently under-recognised and misdiagnosed during life. So today's presentation, I thought I'd cover the diagnostic criteria, some of the current management strategies, and I guess similar to Rebekah, the landscape for clinical trials is difficult, and so I thought I'd cover some of the challenges around that. And this graph was a good way to start. I guess it's similar to the Alzheimer's disease treatment pipeline. It summarises publications by year across Alzheimer's disease, Parkinson's disease and dementia with Lewy bodies. Now you can see in Alzheimer's disease from 1995, you can see an increase in the publication output in Alzheimer's disease. And then you can compare that with Parkinson's disease, and quite clearly, dementia with Lewy bodies is lagging a long way behind that. in the purple there. So we do have a long way to go. And why is it important to diagnose, and why is it important to treat? Well, dementia with Lewy bodies does cause significantly greater functional disability than Alzheimer's disease. The care costs are twice that for Alzheimer's disease. Quality of life is worse, and survival is a problem. The duration of survival is much lower than in Alzheimer's disease. In terms of the clinical diagnostic criteria, they were first operationalised in 1996 and since then have undergone a number of revisions. And the main reason for that is because whilst even the initial criteria were very specific, so a diagnosis was quite accurate, the sensitivity has been a problem. So often cases are misdiagnosed and under-recognised during life. So the most recent revision of the criteria include both core and supportive clinical features, and for the first time biomarkers have been added with indicative and supportive biomarkers. Going through those features of the clinical diagnostic criteria, the core clinical features include motor Parkinsonism, visual hallucinations, REM sleep behaviour disorder and cognitive fluctuation. Now, motor Parkinsonism doesn't occur in all people with DLB. It's around 50% at diagnosis, and it's often the postural instability and gait disorder subtype rather than the tremor dominant subtype that's more typical of idiopathic Parkinson's disease. Now, visual hallucinations occur frequently, and they're often well-formed and often of children, people or animals. Now, the response to the hallucinations can vary from indifference to being quite frightened, and that is very variable. REM sleep behaviour disorder was revised in this round of the criteria, and it refers to loss of muscle atonia during REM sleep. So people in REM sleep are usually, with REM sleep behaviour disorder, will act out their dreams, and they're usually of a violent or thrashing nature. Often that symptom or condition can occur many years before the onset of cognitive symptoms, so that again, that's a really important characteristic to ask about. Cognitive fluctuation, whilst it's a core feature and characteristic of DLB, it's actually very difficult to assess clinically, and it refers to that internally driven variability in attention and arousal rather than that imposed from perhaps increasing cognitive load, as you may see in other forms of dementia. Now, to make a diagnosis of either possible or probable DLB, you need either one or two or more core clinical features. So what's important to note is that you don't need all of the features of core clinical features to make a diagnosis of DLB. And I often find that people are a bit reluctant unless they're very convinced that there's, say, at least 3 of those features. In terms of the supportive clinical features, one of the most important aspects is severe antipsychotic sensitivity. Now, this doesn't refer to side effects such as worsening of Parkinsonism with antipsychotics, which can occur in anyone. But this refers to quite profound changes in conscious state, which can be fatal. So it's really important to be aware of that. It can occur in about 50% of people with DLB. And the reason it's extremely important is because if you link that back to the fact that we often misdiagnose and under-recognise the condition, people admitted to hospital may not have the diagnosis. You may not be aware of that. Other supportive clinical features are important clinical signposts, but they don't contribute to the diagnosis of either possible or probable. So postural instability, syncope, autonomic dysfunction, hallucinations in other modalities. And one of the aspects that's really common is depression, anxiety and apathy. And this is really important to consider, but it does occur in other forms of dementia, which is why it's not a core clinical feature. In terms of the indicative biomarkers, there's 3 in the diagnostic criteria. So DAT scan, or reduced uptake in the dopamine transporter. You can see an abnormal scan here. Unfortunately, it's not available to us in Australia. You've got changes in MIBG scans, and also a sleep study. So looking at REM sleep behaviour disorder through sleep studies can be very helpful. Now, despite that, there remains problems in diagnosing DLB because many patients with DLB don't present necessarily with typical or characteristic symptoms. The other difficulty we can see is that there's insufficient neuropsychological evaluation. And I alluded to the fact that you can have preserved memory with changes in attentional function, and associated with that is working memory, as well as visuospatial impairment. So particularly in the Australian context, where access to neuropsychology evaluation may be limited, particularly for rural and regional centres. Now, also is the underuse of the possible DLB diagnosis. And if we reflect on when we make a diagnosis of Alzheimer's disease, people don't always have all of the clinical features in order to do that. So again, considering even with one of the clinical features, the diagnosis. Also, I alluded to the difficulty with recognising or defining cognitive fluctuation, and it's important to ask about that. Confidence with assessing motor symptoms for clinicians, and also failure to ask about some of those core and supportive clinical features. And these are the most common that are less frequently asked about. In terms of the management, it's a complex and multi-system disease. You can see it affects multiple domains: sleep, cognitive performance, psychotic features, depression, anxiety, apathy, motor symptoms, as well as autonomic. So with that, it's crucial to have a multidisciplinary team approach. You can see that the accuracy of diagnosis is important. Patients with this condition often have numerous specialists involved in their care, whether it's across their cognitive function, psychiatric symptoms, bladder symptoms, sleep symptoms. So you can see that coordinating that care is a priority, and really identifying those symptoms that need treatment. And that may change over time. So prioritising symptoms that require treatment. Education and engagement is really important, and supporting care providers. The therapeutic challenges are certainly there for DLB, and often because of that multidisciplinary approach, you can see that sometimes if you treat one aspect of a symptom, say motor symptoms are a problem, the treatment can in fact worsen other symptoms. So that may then worsen the psychiatric symptoms. So there's this constant sort of line that you're sort of trying to optimise their care, and that can change over time. So again, it's really important to review regularly. In terms of the management, there's been relatively recent systematic reviews for the non-pharmacological interventions as well as the pharmacological interventions. So I'll just summarise those. And if you think about what evidence is available, and thinking back to Rebekah's talk, with very few clinical trials available, DLB is similar. There's only 5 high-quality, reasonably sized randomised controlled trials in DLB. So 3 with cholinesterase inhibitors and 2 with memantine. So overall, cholinesterase inhibitors are quite good and certainly worth trialling, particularly rivastigmine and donepezil. And memantine is a maybe. So in terms of the non-pharmacological interventions, most of the evidence is actually in Alzheimer's disease and Parkinson's disease rather than in dementia with Lewy bodies. So interventions can be patient or caregiver focused or both, and there's preliminary evidence. Exercise and gait training, caregiver education and training, particularly in the management of psychiatric and behavioural symptoms, and this is really crucial. Honey thickened fluids for swallowing difficulties as well, but again, these are really preliminary evidence. In terms of the pharmacological treatments available, there's class 1 evidence for cholinesterase inhibitors, with improvements across cognition, global function, as well as activities of daily living. And importantly, open label studies have suggested that actually patients with DLB are less likely to deteriorate whilst taking them. So we used to think about when to stop cholinesterase inhibitors, but certainly even in DLB now, the recommendation would be to continue them indefinitely unless there's a particular reason not to. Now, moving on to memantine in DLB and in Parkinson's disease dementia, there's been 2 randomised controlled trials with inconsistent treatment effects. So it looks promising, it's a maybe, as I said, but it's a well-tolerated medication, and there were some improvements in global impression of change in both studies, cognitive function in one study and psychiatric symptoms in the other. And what also emerged through subgroup analysis was the possible synergistic effect when also taking cholinesterase inhibitors. Now, they're all symptomatic treatments, and we can also consider symptomatic treatments across all of the other aspects of care in terms of sleep disorders, motor symptoms, but unfortunately there's not the time to go through that in detail. But I thought that potential disease-modifying therapies may be of interest, and certainly it's an area of growth in Alzheimer's disease. In dementia with Lewy bodies, there's far less. So the treatments that are potentially disease-modifying are across targeting alpha-synuclein, so the main pathological substrate of dementia with Lewy bodies, autophagy enhancers, so that's across ambroxyl and tyrosine kinase inhibitors, P38 inhibitors, and phosphodiesterase inhibitors. So you can see that the first class is in healthy volunteers and is still in phase 1, but is potentially acting on alpha-synuclein. The autophagy enhancers, you can see phase 2 and recruiting, and these are not available to us in Australia. And then the last ones you can see again, phase 2 studies in DLB. So what are the challenges for DLB trials? I mean, we have robust diagnostic criteria for Lewy body dementias, but DLB is really seen as a high-risk trial population. And these are the host of reasons that are often discussed. It's hard to recruit, sensitive to adverse events, fluctuations, cognitive fluctuations can introduce variability in outcome measures. Clinical outcome measures are not ideal for the patient group. They're usually, say, borrowed from Alzheimer's disease or Parkinson's disease. And there's no biomarkers at this stage that correlate with disease progression or the response to treatment. So, and there's also heterogeneous response. So thinking about the recruitment challenges, hard to recruit. Alzheimer's disease investigator sites are not generally suitable, but there's no DLB trial network yet established. Now in the US, they have Lewy body research centres of excellence. In the UK, and certainly the NIH in the US has also established a DLB consortium. The European DLB consortium is also a network across Europe and involves the UK. And more recently in Melbourne, we've started a study, an observational study recruiting patients with DLB and PDD for a clinical and biomarker study. And we've been able to establish new sites now in Perth, led by Andrew Ford, and also Shepparton, led by Ravi Bhatt. And Sydney also has an established site, led by Simon Lewis. So again, perhaps there is opportunity for clinical trials in Australia. And what about sensitive to adverse events? Well, caring for people with dementia with Lewy bodies, they do seem to be anecdotally sensitive to effects of medications. But if you look at trial evidence for this, the dropout rate due to adverse events are similar in placebo and treatment groups. And what about fluctuations introducing variability in the outcome measures? Well, it is part of the condition, and it's important to try and assess consistent time points. So thinking about that fluctuation cycle and try and ensure there's some consistency around that. Using measures which are insensitive to day-to-day variability, or even assessing over longer periods. So wearable technology, for instance, has become an area of interest for DLB research for that reason. And also considering change in fluctuations as an outcome, and importantly, using patient-centred outcomes. And you could see from previous trials, the global impression of change seems to be the main scale used in DLB studies. So moving forward in DLB trials, we can consider potential disease-modifying therapies, and we've touched on a few areas of interest at the moment, targeting early stage disease. So thinking about moving that, at the moment, we're having difficulty making a diagnosis, but if we can move that forward to either the MCI stage or even during when people develop symptoms, say, of REM sleep behaviour disorder, that might be very helpful. Novel approaches, including non-pharmacological treatments, and thinking about repurposing drugs from other diseases. So I'll finish with the final slide highlighting a new Australian clinical trial in Lewy body dementia, which is very exciting. I'm leading this. It's a phase 3 randomised placebo-controlled study of memantine in addition to cholinesterase inhibitors in dementia with Lewy bodies and Parkinson's disease dementia. So it's an investigator-initiated and led study, and it's in collaboration with the UK, led by John Paul Taylor and Susanna Walker from Newcastle University and UCL. So we're in the preparation stages at the moment and plan to commence recruitment mid next year. So hopefully we'll have our network established by then to be able to recruit effectively. Now, I'd really like to acknowledge the support of my teams across the Royal Melbourne Hospital CADMS, Memory Clinic, the WeHi, and also the Cobalt team. Thank you.
Thank you, Rebekah and Rosie, for the excellent talks, and also for finishing on time to give us a few minutes for questions. And I think the points you raised are very relevant to the Memory Clinics network that we're putting together, because many of these clinics are interested in referring patients for trials. And in fact, one of the first questions, I think, is from Sharon Naismith to Rebekah in particular, in terms of referring patients. For example, if you need patients for your trials who have a gene mutation or measurement of tau and NFL, so how should clinicians proceed if they have, say, someone with behavior variant FTD or language variant FTD? What should they do?
So the trials, obviously smaller centres and centres that don't kind of, I guess, specialise in FTD won't have available resources to check tau and NFL and genetic status. So all of the trials have incorporated that. So if you've got a patient that has, for example, behavioural variant FTD and a family history, we'd be happy to see them and do the screening, as with the site in Melbourne and also Perth. So if you just get in contact with us, we are happy to do the screening.
Okay, and you have this information available on some website?
Yes, so yeah, if you go to the Frontier website, and also I'll share my slides from today as well, which will have the email address of the trial coordinators in Sydney, Melbourne and Perth.
Sure, wonderful. We might put that on our ADNeT website as well. I think that would be useful. So the other question, interesting question from Dr. Natarajan is about phenocopies. I think there's a lot of talk about phenocopies. What are they? How do they differ from pre-symptomatic FTD, and what's really going on?
Yeah, so I mean, that's an interesting question. So when we use the term pre-symptomatic, we mean people who are in a family that we know have a genetic mutation. So for example, their father may have had FTD and had a granulin mutation, and they've the son of that person and they've been screened for the genetic mutation and they know that they've got the mutation but they don't show any symptoms of FTD. So we would call them pre-symptomatic. Phenocopy is different. So that's a group of patients that John Hodges first described, I think probably in the mid-1990s. And what he noticed was there was a group of patients that were in their mid-60s who came to his clinic in Cambridge and they had all the symptoms of FTD, but they didn't progress. So they had behavioural changes, emotion processing changes, but they didn't have any atrophy on their brain MRI, and they could go for 10, 15 years and they stay stable. So they don't develop atrophy on their MRI, their cognitive scores don't decline, and we don't know what those patients have. A group of them may have the C9orf72 mutation and be very slowly progressing cases of true FTD, but another group we think are probably patients that have always been on the Asperger's autism spectrum, and they get to the age of 60 and for some reason they decompensate. But essentially they're patients that look like they have behavioural variant FTD, but they don't have brain atrophy and they don't decline.
So have there been genetic studies of these patients?
Yeah, so there have been some genetic studies, and a certain proportion of those phenocopic cohorts will have the C9orf72 mutation.
Yeah.
And we do know that patients with the C9orf72 mutation can go for kind of 10, 20 years and be very slowly progressing. I remember I had a family where the mother developed symptoms of FTD and Parkinsonism in her 80s.
Okay.
And it was perfect up till then, but then the son developed it in his 50s. So we don't know with the C9orf72 mutation why some people get it in their 50s and some people in their 80s.
Okay, thank you. So Rosie, a couple of questions for you. The first one is about nocturnal vocalizations. Are they indicative of REM sleep disorder? You're on mute, Rosie.
Yeah, it's a really good question, and I think a difficult one to answer. You wouldn't necessarily, it would be a consideration, particularly with someone that was developing dementia or had some cognitive symptoms that were concerning, and particularly if they were in the profile of also dementia with Lewy bodies, such as attentional impairment, executive dysfunction. If in doubt, though, I think a sleep study is worthwhile. It doesn't always give you the answer, but it also can exclude other causes for those symptoms, such as sleep apnea.
Okay. The other question is in relation to managing postural hypotension. Is that something you encounter frequently? And yeah,
very frequently, and it's a really good question. And this is a challenge we have. And I think that as a geriatrician, it's a condition that covers all of the sort of geriatric syndromes in one condition.
Yeah.
And autonomic dysfunction is fairly common and often will drive postural hypotension, but not always. So the treatment's not specific for DLB in terms of you would use the usual measures and make sure that you look at the antihypertensive therapies, for instance, and if there's anything reversible from that perspective, and education around, you know, standing up quickly and that sort of thing.
Yeah, okay. An interesting question from Jane Thompson about patient and public involvement for recruitment of in trials, really. I mean, I know there is a self-help group as well for DLB, I think a support group internationally. I don't know whether there's one in Australia.
We've been really fortunate actually with the Cobalt trial. So as I alluded to, that was a commissioned call from the NIHR to work with the NHMRC on this, and part of the UK has a very well developed PPI, so patient and public involvement, and really we're at the start of designing that trial, which is why a lot of the I guess the questions that we're looking at in that trial were formed from PPI involvement. And with that, we do have an Australian PPI involvement that is actually networking with the UK as well on that.
Okay. So the question from Chris Rowe is one from Dr. Narayan again, which I'll come to in a moment. Chris Rowe basically says, what are your recommendations in relation to imaging? Because I think that's one thing that maybe ADNeT would be interested in say, developing around the country. And I understand there was, say, data imaging was available in Sydney. I think, again, it's gone off. It's no longer continuing, but for a period, it was available. So what is your recommendation as to what should be available for DLB?
For DLB, I wasn't sure if it was FTD.
No,
But
DLB.
certainly everyone seeking being investigated for cognitive impairment will have structural imaging, and looking at relative preservation of the medial temporal lobe is helpful, but that's only in about half of the patients with DLB. So it doesn't exclude, if you do have medial temporal atrophy, it doesn't mean you don't have DLB.
Yeah.
In terms of the best imaging is DAT scan.
Yeah.
It really is. It's actually better than a clinical diagnosis from studies, but we don't have it in Australia. It's looking like it won't be licensed for use here. And Chris would be well aware of those challenges. So with that, I mean, certainly he's done some really, fantastic work looking at the cingulate island sign as well in PET imaging. So that's using FDG PET. So that would probably be the next step.
Yeah, but I mean, for that, do you generally go with SPECT, or do you also have PET ligands for dopamine transporter?
There are PET ligands.
Yeah.
So I mean, Chris in Melbourne has we have VMAT imaging as part of research, which is very similar, but it's not DAT imaging, and that's with SPECT or PET.
Okay. So I think another question is measuring progranulin in the blood or CSF. Is that available?
So it's not available clinically, but it is available as a research tool.
There is a lab in Australia doing it?
So Glenda Halliday's lab in Sydney will do it as on a research basis. But the main way is to identify granulin mutations is still doing genetic testing.
Sure. And is it available for both CSF and blood, or just CSF?
Just blood.
Blood. Okay. Yeah. Okay. So I think one question which I skipped was cognitive fluctuations, and I guess this is a common question clinicians ask. How do you distinguish them from delirium?
Yeah, well, I guess in delirium, it's a little bit different because people are often in hospital and unwell, and that would be a distinguishing factor. And the cognitive fluctuations typical of DLB, as I said, you often get a history from a family member, but more frequently you'll observe them during the hour consultation anyway. In terms of scales to measure it, the two pretty good scales, I'd say, are the Mayo fluctuation scale and the clinician assessment of fluctuation. So the Mayo fluctuation scale and the clinician assessment of fluctuation is one from Newcastle in the UK. So they're the two scales that we typically use in studies anyway. And I must also mention, I didn't get time to add this to the slides, but there's a Diamond Lewy study based in the UK which looks at trying to improve the diagnosis and has a specific diagnosis and management toolkit, and that also it's a very clinical toolkit, and it really goes through each of those core features and how to assess them in the clinic with particular scales. So that's worth looking at.
Yeah. Okay. I think that's about it. I guess we almost on the dot at 5 p.m. So thank you again for these excellent talks and for responding to the viewers' questions. So I think it's been a wonderful session. I really I'm pleased that, I mean, of course, we have no technical hitches, which is thanks to Joe, who manages so expertly. And of course, this is a regular feature, and we're going to have similar symposia in the coming year. So keep on the lookout for further news on this. And of course, you're welcome to visit the ADNeT website and get more information about memory clinics and the other initiatives of ADNeT. And of course, do not forget to complete the questionnaire at the end of this survey at the end of the talk. Thank you again. Bye for now.